Hello and welcome. Today we'll be exploring a rare and complex kidney disease known as monoclonal immunoglobulin deposition disease, or MID. This condition affects the urinary system and can lead to serious kidney damage. Join us as we delve into the causes, symptoms, diagnosis, and treatment of MID. So, what exactly causes MID? At its core, MID stems from a problem with plasma cells in the bone marrow. These cells, which normally produce a variety of antibodies to fight infection, start churning out a single type of abnormal antibody, called a monoclonal immunoglobulin. This monoclonal protein isn't fully functional and tends to clump together, leading to deposits in various tissues, especially the kidneys. It's often associated with plasma cell dyscrasias like multiple myeloma or monoclonal gammopathy of undetermined significance, also known as MGUS. But sometimes, MID can occur without an identifiable underlying plasma cell disorder. The precise trigger that causes this monoclonal protein production remains unknown in many cases. Let's understand how MID affects the kidneys. The abnormal monoclonal immunoglobulins deposit themselves within the delicate structures of the kidney, primarily the glomeruli, which are the filtering units. These deposits disrupt the normal filtration process. They can clog the glomeruli, thicken the surrounding membranes, and eventually lead to inflammation and scarring, a process known as glomerulosclerosis. Over time, this damage reduces the kidney's ability to filter waste products from the blood, leading to kidney dysfunction and eventually kidney failure. MID is considered a rare disease. The exact prevalence is difficult to determine, as it's often underdiagnosed and can mimic other kidney diseases. It's estimated that MID accounts for a small percentage of all cases of kidney disease diagnosed through kidney biopsies. It can affect individuals of any age, but it's more commonly seen in older adults, typically those over the age of 50, reflecting the increased incidence of plasmal disorders in this age group. The signs and symptoms of MID can be varied and often non-specific, making early diagnosis challenging. Many individuals initially experience proteinuria, which is protein in the urine, often detected during routine medical checkups. As kidney function declines, symptoms like edema or swelling, particularly in the legs and ankles, fatigue, and high blood pressure may develop. In advanced stages, symptoms of kidney failure such as nausea, loss of appetite, and shortness of breath may become prominent. Diagnosing MID requires a multifaceted approach. The starting point is usually the detection of proteinuria during a routine urine test or the discovery of kidney dysfunction based on blood tests such as serum creatinine and estimated glomerular filtration rate (GFR). A definitive diagnosis requires a kidney biopsy. The biopsy sample is examined under a microscope, and special staining techniques, like immunofluorescence, are used to identify the presence of monoclonal immunoglobulin deposits. Furthermore, blood and urine tests, including serum protein electrophoresis and immunofixation electrophoresis, are performed to detect and characterize the abnormal monoclonal protein. Bone marrow aspiration may also be considered to evaluate for underlying plasma cell dyscrasias. MID can be further classified based on the specific type of monoclonal immunoglobulin that's being deposited. The most common types are light chain deposition disease (LCDD), where only the light chain component of the immunoglobulin is deposited, and heavy chain deposition disease (HCDD), where only the heavy chain is deposited. Sometimes both light and heavy chains are deposited together, which is referred to as light and heavy chain deposition disease (HCDD). The specific type of immunoglobulin involved can influence the clinical presentation and the prognosis. The treatment and management of MID focuses on slowing the progression of kidney damage and addressing any underlying plasma cell disorder. Treatment strategies often include chemotherapy or other medications designed to suppress the abnormal plasma cells in the bone marrow, thereby reducing the production of monoclonal proteins. Medications to control blood pressure and reduce proteinuria, such as ACE inhibitors or ARBs, are also frequently used to protect the kidneys. In advanced cases of kidney failure, dialysis or kidney transplantation may be necessary. Currently, there are no specific preventative measures for MID. Given that MID is often linked to plasma cell disorders, early detection and management of these disorders may potentially reduce the risk. Regular medical check-ups and monitoring of kidney function, especially in individuals with a family history of kidney disease or those at risk of developing plasma cell disorders, are essential. The prognosis for MID can vary considerably depending on the severity of the kidney damage at the time of diagnosis, the type of monoclonal immunoglobulin involved, and the response to treatment. Early diagnosis and aggressive treatment can significantly improve outcomes. However, MID can progress to end-stage renal disease, requiring dialysis or kidney transplantation. Recent research is focusing on developing more targeted therapies that specifically target the abnormal plasma cells and the monoclonal protein production, potentially leading to more effective treatments and improved long-term outcomes. There's also ongoing research investigating the genetic factors that may contribute to the development of MIDD.